Hello, my name is Roland Quintana Rapitalo, and I'm a medical student at the Florida International University Herbert Wertheim College of Medicine in Miami, Florida. I've also partnered with medical students Devang Frata, Yvonne Ward, Kevin Healy, Stefan Anthony, and Dr. Michael Herman. We are presenting a case report entitled Cecal Endometriosis Presenting as Hematochezia in a Postmenopausal Female. Our goal is to bring awareness towards intestinal endometriosis as a differential diagnosis to be considered in women, regardless of age, with intermittent hematochezia and abdominal pain. Our case report is centered around a 51-year-old female who presented to the emergency department for evaluation of syncope and gastrointestinal bleeding. She was brought via emergency medical services after being found on the floor by her husband with blood surrounding her. EMS described the patient's blood as dark red. For the past month, the patient endured suffering from intermittent hematochezia with severe abdominal pain during the episodes. She had no other associated symptoms. She additionally had no personal or family history of colorectal cancer or inflammatory bowel disease. Her last colonoscopy was 1 month prior to presentation, which revealed benign findings. On admission, the patient was alert and oriented to person, place, time, and event. The patient appeared slightly pale and showed signs of apparent distress. Vital signs upon admission showed a blood pressure of 117/65 millimeters mercury, pulse of 67 per minute, temperature of 97.8 degrees Fahrenheit, respiratory rate of 18 per minute, and oxygen saturation of 99%. The patient denied nausea, vomiting, hematemesis, hemoptysis, fever, chills, and urinary abnormalities. Physical exam revealed a tender abdomen in the right lower quadrant with mild pain with palpation. Labs reveal low hemoglobin at 9.9 grams per deciliter and low hematocrit at 29.4%. The patient's partial thromboplastin time was low at 22.8 seconds, and glucose levels were high at 119 milligrams per deciliter. All other lab values were within the normal limits. The patient underwent CT angiography of the abdomen and pelvis, which revealed no evidence of an active gastrointestinal bleed. There was no evidence of significant stenosis, dissection, or aneurysm. The patient was advised about her current situation, and she was discharged with scheduled follow-up visits with gastroenterology. A follow-up colonoscopy revealed an erythematous nodule embedded in the cecum. Multiple biopsies were taken from the cecum. The pathologic examination showed ectopic endometrial glands in the cecum. There was no microscopic evidence of any other pathologies. Given the absence of other possible etiologies, we attribute her hematochezia to cecal endometriosis. The patient was recommended to follow up with an outpatient gynecologist for consultation and long-term management. So why did this happen? Endometriosis is the ectopic proliferation of endometrial tissue outside of the uterine cavity. Endometriosis most commonly involves the ovaries, fallopian tubes, and pelvis lining. Rarely, endometrial tissue may be found beyond areas where the pelvic organs reside. Bowel involvement in endometriosis is uncommon, but when it occurs, it is usually localized to the rectosigmoid and less frequently in the cecum. Additionally, endometriosis is common in women of childbearing age. In postmenopausal females, the prevalence is reported to be around 2 to 5%. To date, there have been 2 reported findings of cecal endometriosis in a postmenopausal female. However, none have presented with hematochezia. Our case highlights cecal endometriosis as a differential diagnosis to be considered in women, regardless of age, with intermittent hematochezia. Current literature comments on cecal endometriosis presenting as acute appendicitis, intussusception, volvulus, chronic abdominal or pelvic pain, or bowel obstruction. However, our report identifies an additional clinical presentation of cecal endometriosis presenting as hematochezia. A high index of suspicion is required for diagnosis, especially if the woman has a history of cyclical abdominal pain. We urge further research to be completed to identify additional unique clinical presentations of cecal endometriosis. Thank you.